Kayla has a tough act to follow. She's already been introduced, um, but she's going to be talking in her role as the AIM healthcare nurse educator, working with the Vermont Alliance for Innovation on Maternal Health and the PQC teams to implement obstetric patient safety bundles with all Vermont nursing hospitals. So we're excited to hear this aspect of your work, Kayla.
Great, thank you, Molly. And yes, I really don't want to have to follow that because that was just amazing. And I think, like somebody said in the chat too, like that's why we do this work, why we put our energy in, right? So I'm going to share with you today a summation of the patient safety bundle just for awareness on other work that's being done. We originally did this webinar back in January as a full hour, so this is just a condensed version to share for those who may not have been at our AIM webinar. Next slide, please. My only disclosure is this webinar is supported by HRSA. That is the grant that we function under as the AIM capacity grant. So just doing that small disclosure. And next slide, please. All right, so we started this work. There's a lot of history behind it, but it comes to both the perceptions of our nurse leaders and when picking the next AIM bundle to work on, like what do they feel like we should be working on throughout the state, as well as our data. So I'm going to share a little bit of data that we have that it helped ground us in this work. Next slide, please. This is not specific to perinatal people, but we thought it was interesting to look at as Vermonters in general and the treatment for primary substances over the course of the last 9 years. Um, so just showing the rates and the different substances, because a lot of the focus that we have with AIM obstetric safety bundles is universally educating patients or universally screening patients. Like we don't always know who's using substances. We don't always know who's at risk for preeclampsia or who's going to develop it. We don't know who's going to have a postpartum hemorrhage. So trying to advocate for universal education so patients can advocate for themselves and have the systems in place. So when risks are identified for various obstetric complications, that we have tools in place to help patients where they're at. Next slide, please. And this is another one, again, Vermont based. Looking at the type of substance use disorder treatment received by clients in both 2022 and 2023. So utilizing hub MOUD models the most in both years, and then a lot of outpatient focus. So again, a lot of the bundle work is those community connections. And a little caveat, the two bundles we implemented first in the state back in 2021 was obstetric hemorrhage and hypertensive crisis or hypertensive disorders in pregnancy, which are really inpatient focused because that's typically where those events occur. And this bundle is allowing us to kind of break down those silos and really engage with community partners and our clinics, and to ensure this care is more wraparound for the whole spectrum that a patient is both prenatal and through postpartum. So we were trying to get a lay of the land, looking at what data was already available, and then we did a little work collecting some data ourselves. So we'll go to the next slide. I don't think this slide has been shared yet today, so I'll pause and make sure I go through this. So this is specifically from the MMRP data, which Lisa and Katie have both referenced. But since 2012, 43% of perinatal deaths in Vermont were a result of accidental overdose. So again, highlighting the fact of trying to make sure that we are broadening our outreach and our education. And substance misuse contributed to a significant majority of these overall deaths. And then of the 8 deaths since 2021, all were related to opioid misuse. 7 directly to overdose and 1 by endocarditis due to the IV drug use. So we started out broad looking at, Vermont data, knowing that we were going into this bundle, and then tried to hone in a little bit more on the perinatal field. Next slide. think is the one we've shared already, but to reinforce when the timing of the deaths at both state and national levels. So while pregnant or day of delivery, and this is for any maternal deaths, Vermont, we have a lower percentage than across the state in that time frame. Within the first 42 days, we're substantially lower. But then where we unfortunately go in the opposite direction is after that 42-day mark. So 43 to 365 days is when we exceed national levels. So again, this is helping us focus our efforts. Next slide, please. Another way of looking at it, I borrowed this from the ICON report last year, but this again shows it's looking at the percentage of pregnant patients who deliver an opioid-exposed newborn and whether or not they were on treatment and then what the treatment was, either buprenorphine or methadone. And unfortunately, what we're seeing is an increase in perinatal patients not being part of a program with opioid exposure specifically. So again, it keeps reinforcing this mantra that we have of like universal dissemination of information and supports. Next slide, please. This is another version of a slide I think Dr. Shepard shared in the intro, but just all the different work going on in the state. It's really for a small state, I feel like we're really fortunate that there's so much work and passion behind these projects, and we're trying to all work together and grow in the same direction, which is really nice. Next slide, please. So we wanted to reassess clinics, OB clinics specifically, those caring for perinatal patients. One, to start building networks with them because, again, we were focused inpatient in the first part of our AIM implementation. And surveys hadn't happened since before COVID, and we know COVID changed the landscape of clinics tremendously. So we did think it was appropriate to kind of resurvey, kind of make those connections and start diving in even deeper into the perinatal field. So 10 out of our 11 health districts have clinics that serve perinatal people, and 16 clinics were identified throughout Vermont. And we ended up having a 13 out of 16 respond for an 81% response rate. So we were happy with that amount. And we did this starting in October of 2024 and collected responses up through January of this year. Next slide, please. So today I pulled out some of the ones that I thought would be of most interest to this audience based on our host recommendations. And we asked a lot of questions around screenings, types of screenings, timing of screenings. Like we're just trying to get a lay of the land because a lot of the bundle focuses on screening and we want to see where we're at and where we should focus our efforts. So fortunately, 100% of our practices reported screening at some point during pregnancy. And on the box shows the different types of screening, what we're screening for at these OB clinics. The first section is looking at any prenatal visit, so super high rates that during pregnancy patients are being screened. And then we looked at the delivery stay because it's pretty mixed throughout the state as to whether there's systems in place for rescreening at time of labor and delivery. As you can see, percentages drop off a lot. I do think there are unfortunate silos between the OB clinics and the inpatient worlds. So I do take that with a little bit of a grain of salt. Sometimes we don't know what each other's doing inpatient to outpatient. But then looking again at the postpartum visit, so back in the clinic setting, what types of screenings are being done and at what percentage were clinics reporting that they were doing these screenings. The purple bar, which is our tallest bar, is for screening for depression and anxiety. It's probably not surprising to a lot of people that that's where the focus is. But as we can see, all the other ones related to substances really drop off and are not necessarily being rescreened in the OB setting. So I wanted to bring that awareness. Next slide, please. This dives a little bit deeper into the first prenatal appointment, which is what the AIM recommendation is that patients are screened on first arrival to obstetric care, and compared that with that postpartum visit. So as we can see, high percentages in that first prenatal visit, especially around mental health and substance use between, tobacco at the lowest at 84%, but in the 90s and up to 100 for a type of mental health screener. And then again, the postpartum one is focused mostly on the mental health side in specifics, depression, anxiety, or other mental health diagnoses. I do want to highlight, because I always like to, that this is very specific to the clinics. So we know those patients who are getting wraparound services with home health. Home health has their own evidence-based screeners that they do and at different intervals. So that is not capturing this. So a bigger percentage of postpartum patients are being screened for these things, but it's not captured in this data because this is based on the 13 clinics that we surveyed. Next screen slide, please. And then want to dive in even further for that inpatient admission and then postpartum visit, because that's when at least pediatric providers are mostly, that's the time frame that the pediatric homes are involved. So as you can see, very few referrals are made during the inpatient stay, which we could probably give many reasons for why that's the case. But postpartum visits, the referrals do pick up in the OB clinics. But as we've been kind of preaching today, we're really trying to flip that. So antepartum, there's a much more uptick of referrals and referrals being accepted. So those relationships are already built and resources already in place before they get to the postpartum phase. Because many of us who have experienced childbirth and postpartum can probably attest it is a very wild and crazy time, and you're just like holding on for a ride. And you, one more phone call or one more, intake form might kind of be on the bottom of the list. So we're really trying to change that script and front loading resources and showing patients and families how beneficial that is. I think part of it is we get more uptick in the postpartum phase because the baby's here, and a lot of evidence shows that when you frame things of this will be a help for your baby, there's more acceptance. But we need to, figure out how we can prioritize the maternal side of things too, and for patients to uptake, feel that their needs are important too in the prenatal setting. Next slide, please. And we were also interested in how are referrals made, because a lot of feedback that we received early on is there's barriers to actually putting in a referral. So we were trying to look at different ways of looking at this. And one of it was like the physical mechanism of how a referral is made. And so you can see across the state, there is a wide variety of whether things are built into electronic health records, if it's by email, if it's by fax, or by phone call. So again, this is just giving us a little bit of a lay of the land to see, and this is broken out by different types of referrals, just so we could see if there was any way to condense referral pathways, hence our Help Me Grow work that we're working on. Just trying to make there be less burden on the provider and the healthcare team side of making referrals. And when we did this, we also had people list the different positions that place referrals. And of the 13 clinics, there were 6 different roles identified as placing referrals. So we also know there's nuances within clinics, there's nuances when positions go vacant. So again, trying to build pathways that more than one position could potentially know. So if there is a vacancy, like things aren't having to be shifted or retaught to make it easier. Next slide, please. And then we wanted to get, kind of opinions. So this first blue box is looking at, does your current referral system work? And as you can see, there is some variety there in responses. So the two ends go from 30 something percent up to 90, but then you can see the mean in the box there. And then the orange was the question of, does your current referral feedback system work? Because we know that is a big component, is people just don't know if the referral got to the patient or if the patient accepted services. So as we can see, there is a lot of work we can do in regards to feedback systems. And these bullets just share some of the notes that we had an open cell box for people to be able to put in comments if they wanted to. And these were the top ones that we saw. Not all referrals are listed in the same place. It's not integrated into an EMR or an EHR. It's hard to tell if a referral was successful, and referral paperwork is cumbersome. So those are the big things of us trying to figure out, is there ways that we can lessen these barriers on the healthcare provider side of things? Next slide, please. So that kind of gave us our focus. Really, like I said, we started at a really high level of Vermont substance use, narrowed down to perinatal, and then we got even deeper into like the clinic side of things in regards of like referral systems and screening. Um, so for the second half, I'm just going to go through the different parts of the bundle that we're focusing on, because again, this was an hour-long webinar before, and there's 70 different action item lines in the bundle as recommendations for improving care of substance use in pregnant and postpartum people. So I'm just going to show you the different buckets of work that we have consolidated and are actively working on. So next slide, please. So screening and testing, differentiating between the two is a really important concept and gets really muddy sometimes. So we've been speaking to that in our webinars, and as shown earlier, as resources available, there are templates available from UVMMC in regards to cord collection and biochemical testing recommendations. We have been, as I've stated, working on referral pathways. Resource mapping, the IDTA did some great work, like we talked about earlier, with some walkthroughs into certain areas. We've kind of mimicked that work in a sense of making a one pager of like the top different disciplines in each region um, for specific to substance use and the supports around substance use. So clinics could have a one pager and not have to reinvent the wheel. So that is currently being worked on. We created a prenatal care checklist. There's some recommendations of how like each patient should have um, specific education prior to coming inpatient. So we made like a little toolkit that clinics can utilize in order to, again, not reinvent the wheel and be able to utilize resources that are already in place with patients. Their community linkages is a huge part of this work. And I think we spoke enough to that, so I won't repeat that. Next slide, please. Looking at protocols and guidelines in all aspects of care, both in the clinic, in the hospital setting, and postpartum, looking at the reporting DCF. So it's, across the board, everyone is up to speed on current practices. And a project that we'll be working on in 2026 will be universal naloxone distribution at the postpartum discharge and inpatient units. Next slide, please. Patient education is a huge part of this. So there's different topics listed there that we are looking at, just either utilizing resources that are already built, revising them, or creating them if they don't exist yet. And then again, same bucket with healthcare provider information. We are looking at some global topics too, like we provided trauma-informed care free of charge webinars and modules across the state. We did a webinar on informed consent. We will be holding a webinar or more than one on stigma and bias. So just trying to provide some of the wraparound global topics that could help all of our patients. And next slide. Okay, a plug for our next upcoming webinar, June 11th, we're focusing on the inpatient setting. And it'll include Dr. Rideout is going to present here on that day with us, which will be great. All our webinars are recorded and available, so if you're interested, please see the PQC website for those. And we're going to take a break in July and August and then resume in the fall, and we're going to have that webinar schedule coming out soon. All right, I think I got through it all.
Thank you so much, Kayla. That was amazing. All of the work with the AIM program and bundles, and just connecting it with the outpatient setting and just trying to break down silos. So it's amazing.
Thank you.
So we are gonna